Welcome back. We are about to start the next symposium on endometrial cancer. I would like to request Dr. Kanishka Karnaratne, consultant gynecological oncological surgeon, and Dr. Samadara Sripali, consultant clinical oncologist, to chair the symposium.
Thank you very much. So, welcome all of you for this important gynae oncology symposium on endometrial cancer. The time is 11:30. I just mentioned the time because the last speaker is from UK. And so I just mentioned the time. It's time in Sri Lanka is 11:30. And so this symposium will be on video presentation by the three speakers. And once every speaker has 20 minutes presentation, and after that there will be a session or 10-minute session on question and answers, and except the last speaker, because it's still very early in UK at the moment. So when it comes to the last speaker, who is from United Kingdom, we'll have his question and answer session in about another half, and once we finish it, half an hour after this symposium. Okay. My co-chair is Dr. Samadara Sripali, who is a gynae-oncologist, who's a clinical oncologist from Anuradhapura, and she will be introducing the first speaker.
Thank you very much, sir. Let's introduce Dr. Lakshan Abeynaike, our first speaker of this session. He is a consultant clinical oncologist, Provincial General Hospital, Badulla. Dr. Lakshan Abeynaike qualified as a clinical oncologist in 2015. He has worked as a fellow in clinical oncology in Colchester University Hospital and as a specialty registrar in Royal Marsden Hospital, UK. He has been working as a consultant clinical oncologist at Provincial General Hospital, Badulla since 2017. Over to you, Dr. Lakshan.
Good day, everyone. I welcome all to the presentation on endometrial cancer. The topic I have been allocated is epidemiology and diagnosis of endometrial cancer. Let me introduce myself. I am Dr. Lakshan Abeynaike, consultant oncologist working in Provincial General Hospital, Badulla. And let me start by giving you an overview. Endometrial cancer is the commonest gynecological cancer in the developed world. However, it is the second commonest gynecological cancer in the developing world, as well as when you consider the whole world as a whole. The cervical cancer is the first gynecological cancer, commonest gynecological cancer. 90% of the cancers in the uterus arise from the endometrium, and the rest arises from the myometrium and stromal cells. The commonest pathological type of endometrial cancer is, of course, the endometrioid variety, and this is usually considered a cancer which with a favorable prognosis. Other types, namely serous papillary as well as clear cell, have an unfavorable prognosis. And globally, when we consider epidemiology, endometrial cancer develops in about 1 to 2% of all females in their lifetime in US, and the peak age globally is between the ages of 60 and 70 years of age. However, 3% of endometrial cancers occur before the age of 40 years. And the incidence of endometrial cancer obviously has been increasing in the recent years. Let me contrast the epidemiology between the developing and the developed world. In UK, endometrial cancer is the fourth commonest cancer among females, and the age standardized rate is 29. We see a similar trend in US as well, where it's again the fourth commonest cancer among females with a similar disease incidence. When we consider Sri Lanka and India, we see lower incidence of endometrial cancer, and its prominence is less. It's the 7th commonest cancer among females in Sri Lanka and 6th commonest cancer among females in India. And in US, the incidence is among white women is higher than among Asian women. So there may be some genetic factors also at play. So when we consider risk factors, let me divide the endometrial. I will emphasize that endometrial cancer is divided as type 1 and type 2. So the type 1 is the commoner one, and endometrioid histology with the FIGO grades, nuclear grades 1 and 2 of endometrioid histology is considered type 1. Type 2 encompasses the FIGO grade 3 as well as all the other non-endometrioid types, namely serous, papillary, clear cell, mixed cell, undifferentiated, as well as carcinosarcoma. They have differing risk factors. For type 1, the pathogenesis is estrogen overstimulation and lack of exposure to progesterone. The pathogenesis of type 2, on the other hand, is less well established. When we consider increased estrogen exposure, estrogen can come as exogenous sources as well as endogenous sources. So the commonest exogenous source of estrogen exposure is unopposed estrogen therapy. In patients using estrogen alone hormone replacement therapy, the relative risk of endometrial hyperplasia is in the range of 10.1 to 2, and a similar relative risk is seen for endometrial cancer as well. The other commonest form of exogenous estrogen is tamoxifen, which is a selective estrogen receptor modulator used in breast cancer. It increases the relative risk of endometrial cancer by about 2 to 3 times. The histology of endometrial tamoxifen-induced endometrial cancers are similar to that of endometrial cancers we see in the normal population. The chromatin citrate, which is also a SERM, acts as an estrogen antagonist when it comes to the uterus, and therefore theoretically unlikely to cause endometrial cancer or hyperplasia. However, the data regarding this is inconsistent. When we come to endogenous estrogen exposure, chronic unopposed stimulation by estrogen, and this can lead to endometrial hyperplasia and cancer. The two commonest scenarios where we see chronic anovulation is the perimenopausal state as well as polycystic ovarian syndrome. And I should mention that some fertility and infertility is not an independent risk factor for development of endometrial cancer, but increases the risk of developing endometrial cancer through the anovulatory cycles, which they tend to have. And obesity also increases the risk of estrogen exposure, because obesity causes peripheral aromatization of androgens, and in fact endometrial cancer, risk of endometrial cancer increases with the degree of obesity. And estrogen secreting tumors also are a rare cause for endogenous estrogen hyperexposure and causes endometrial cancer. Early menarche and late menopause also have been implicated, although to a lesser degree, for endometrial cancer. And then there are some hereditary risk factors. Hereditary non-polyposis colorectal cancer syndrome is an autosomal dominant condition, and it causes about a 60% lifetime risk of developing endometrial cancer. And this is usually found in about 2% of general population, and account for a similar proportion of endometrial cancer. And the Cowden syndrome also confers about 15% lifetime risk of endometrial cancer. The BRCA mutation 1 and 2 are, we don't have any certain association with endometrial cancer, but there's epidemiological association sometimes observed in some data sets. And it is thought that this is mainly due to tamoxifen consumption by the people who are affected by BRCA mutation due to the breast cancer, which is much more common in BRCA mutated individuals. And then let me come to the presentation of endometrial cancers. This is how they in fact present. So as many of us would have seen, abnormal uterine bleeding is seen among close to 90% of patients presenting with endometrial cancer. And however, it should be mentioned that the degree of bleeding is not associated with a higher risk of endometrial cancer. In postmenopausal bleeding, the risk of endometrial cancer is in the range of 9 to 10%. And then some of our patients present as abnormal pap smear. The pap smear will reveal adenocarcinoma in this situation. And about 50% of endometrial cancer patients will have an abnormal pap smear. And sometimes we see endometrial cancer coming up as an incidental finding after hysterectomy is being performed for an unrelated cause. And there have been several study series where they have seen endometrial cancer in about 1 to 2% of hysterectomy specimens that have been performed for unrelated causes. And this incidence of incidental endometrial cancer increases with the age of the individual. So let me see how this is diagnosed. Usually endometrial cancer can be diagnosed by blind endometrial biopsy, which can be performed in the clinic itself, and it is said to have about 90% sensitivity. And if this blind biopsy does not reveal benign pathology, other logical option is dilatation and curettage. Diagnostic hysteroscopy is also recommended in almost all society guidelines to be performed at the time of dilatation and curettage, but this is mainly resource dependent as well as time dependent. However, dilatation and curettage, 60% of DNC samples have been found to sample only half of the endometrium. So that is why this diagnostic hysteroscopy has also been co-recommended to be performed together with dilatation and curettage. And hysteroscopy alone cannot be used actually as a replacement for dilatation and curettage, as close to 30% of endometrial cancers can be missed in hysteroscopy. So then there are non-invasive methods that will come in the postmenopausal state with bleeding. So transvaginal ultrasound scan is a very sensitive method of excluding diagnosing endometrial cancer. In postmenopausal patients, an endometrial thickness less than 5 millimeters is associated with a very low risk of endometrial cancer. So a transvaginal ultrasound scan has a sensitivity to endometrial cancer of about 96%. However, the specificity is low. However, in this situation where we use this as a screening tool, when a woman comes with postmenopausal bleeding, the high sensitivity is quite useful. And it should be mentioned that endometrial patients who are diagnosed with endometrial cancer, the mean endometrial thickness is 20 millimeters, which is quite higher than the 5 millimeter cutoff value we use. In patients using tamoxifen, however, any postmenopausal bleeding should be biopsied. rather than going through transvaginal ultrasound scan route, because the risk of development of endometrial cancer is in the range of 1 per 1,000 patients using tamoxifen. And if one observes, if the operator observes any masses rather than uniform increase in thickness inside the endometrium, then it also should be biopsied, preferably with hysteroscopy, where we can target the biopsy. Then we come to staging. Usually, preoperative abdominal and pelvic imaging is not much done in type 1 endometrial cancer because of the lower risk of metastatic disease. Sometimes ultrasound scans of the abdomen and chest x-rays are used, and sometimes even CT scans are used. However, CT scans for endometrial cancer, to diagnose metastatic disease is used mainly in type 2 endometrial cancer. Endometrial cancer staging is mainly surgical. It is performed intraoperatively. MRI scan, if we are to stage endometrial cancer locally and loco-regionally, MRI scan is superior to CT scans in detecting the myometrial invasion, cervical invasion, as well as pelvic lymphadenoma. CA125, the tumor marker CA125 is not established in type 1 endometrial cancer. However, in type 2 endometrial cancer, the serous papillary and the grade 3 varieties, it is associated, elevation of it is associated with metastatic disease. With this, I think I have covered quite a few of my bases, and thank you very much for your attention.